Okay. So good afternoon, good evening, or good morning to everybody. It's Tim Cranton again from the College of Remote and Offshore Medicine. And our Wilderness Medical Society presentation today for the student interest group is going to be about altitude medicine. And we're going to be discussing various things to do with altitude medicine that include high altitude cerebral edema and high altitude pulmonary edema. So without further ado, what I'm going to do is I'm going to bring my presentation up on a screen and share with you now. And I'll just do a double check. Can everybody see the presentation slide? If I can just get a yes.
Yeah, I can see it.
Excellent.
Yeah, no
Okay,
problem.
great. Excellent. Okay then. So as I said, welcome. For those of you that don't know me, or it's the first time that you've joined one of our presentations, my name is Tim Cranton. As I said, I'm from the College of Remote and Offshore Medicine. I've got a varied background in remote healthcare that includes being an ex-British Army combat medic, and I was a medical instructor with NATO for a while, and have taught the various tactical levels of pre-hospital care. I'm affiliated to the National Association of EMTs, and I was a UK paramedic and a UK fire and rescue as well. So I did my time training as a paramedic with the National Health Service, and then decided that fire rescue was much more fun. So I ended up switching jobs, but had a great time doing that, and it made me realise my passion for remote healthcare. And as has already been pointed out, I'm actually offshore at this moment in time in the not so sunny North Sea. So my neighbour is actually Norway. It would be quicker for me to get to Norway than it would to get back to Scotland and the mainland. I'm a dive medic, and I'm also a director of a training company in the Czech Republic, which is where I live, and a professional practice advisor for the college. And I'm managing the first year of our remote paramedic practice paramedic program. So as I said, today I want to talk to you about altitude medicine. Nice picture here of Annapurna Base Camp. And if anybody's ever been to any places like this, you're going to understand the kind of the sparsity of the environment that you're going to be in. And not the friendliest. It looks great, but there are certainly things there that can catch you unawares, which is what we're going to talk about today. So my objectives for this presentation are going to go through altitude emergencies. I already mentioned HAPE and HACE, but we're going to talk about acute mountain sickness as well. We're going to look at prophylaxis, so how to prevent and treat these conditions, and we're going to break them down into their different causalities. So, welcome. First of all, a definition of what we would call high altitude. So high altitude is basically between 1,500 to 3,500 meters. And if you're going to be traveling to that altitude, you're going to notice a noticeable fatigue during exertion. So it's going to become harder to work in those areas, and you're going to find out why as we work our way through. Very high altitude is defined as between 3,500 and 5,500 meters, where we're going to look at getting hypoxia, because as we understand, oxygen lessens the higher we go in terms of concentration. It's going to be difficult working, and it's going to be difficult sleeping at that altitude. And we would define extreme altitude as greater than 5,500 meters. What we call the death zone. So humans cannot live at this altitude for very long. You may have heard of people going to Everest and climbing Mount Everest and going through or into the death zone. And we'll talk about that as we progress. We've got a little slide there on the right-hand side that kind of takes you through the variations in terms of height and altitude. So for us in the UK, certainly in Scotland, Ben Nevis, that sits at around 1,344 meters. And when we talk about meters, that's above sea level. Everest, however, is 8,848 meters, and that's considerably higher. I've already mentioned that oxygen is depleted at the higher levels or higher the altitude that we go. So if you imagine being at sea level, so Tunisia, but this could be anywhere sea level, you're looking at an average SpO2 of somebody being around 98 to 99% on air. But as we increase our altitude, so in this case Burundi, it sits at around 1,500 meters, we're going to look at a slight drop. And as we go higher and higher and even higher still, so in Nandi Devi, which is in India, 6,620 meters, a significant reduction down to 65% SpO2. And then if we were to go to the top of Everest at just over 9,000 meters, we're looking at 59%. Again, a significant reduction in terms of oxygen concentration in your blood. At the end of the day, you have to be acclimatized to be able to travel to those altitudes in the same respect, because of the extremes in altitude and obviously a significant reduction in SpO2, you will suffer effects. There will be detrimental effects because of the lack of oxygen. So in terms of acclimatization, so obviously that means going up slowly, that's the key to the physiological changes that you or your body is going to need to make to be able to adapt to living and, I say working, but moving and operating at high altitude. Everyone is different. Nobody is the same. So different people will adjust at different rates. Fitness does make a difference, but it's not necessarily a predictor. I've certainly known various people that were super fit, but they actually suffered from acute mountain sickness at quite lower levels, whereas people that you didn't think were as necessarily fit as these other people didn't. So not everybody is the same. Above 3,000 meters, we are only looking to ascend by around 300 meters a day for us to be able to acclimatize. So the same that we would acclimatize to a hot environment, we need to acclimatize to an environment where there's a depletion in oxygen levels. The saying is climb high, sleep low, and that's a core tenet of acclimatization. Obviously, we want to get fit and we want to be as fit as possible, but that fitness includes acclimatization and your body being used to operating at a depleted oxygen level. As I mentioned, we are looking at people getting sick if they don't acclimatize. Now, there are many types of altitude type emergencies. At the end of the day, somebody could quite easily have a climbing accident. That's obviously going to be trauma related, and they could have back injuries, they could have spinal injuries, they could have bruises, bumps, scrapes, and any number of traumatic type injuries. But then, is that because they are not acclimatized to altitude and their body is not working as they would normally expect it to work? Maybe they're not able to think as clearly as they would normally be able to, and they make mistakes. And that could most certainly be a precursor to somebody having an accident or an incident. At the end of the day, accidents and injuries do occur. So as I've mentioned, we have high altitude pulmonary edema and high altitude cerebral edema. But we also have a third, and that is acute mountain sickness. And if anything, that's kind of the first one that we tend to come across when we look at altitude issues or altitude emergencies. If any of you out there have got your field guides handy, you can flick through the pages and you will find that we've actually got a page there that relates to altitude emergencies. And it will give you a list of things that you can expect to see in terms of symptoms And it will also break down those symptoms. So you've got symptoms for AMS, symptoms for HAPE, and symptoms for HACE. You've also got your treatments as well. So this is a handy tool if you're not quite sure. But at the end of the day, if you're going to be going to any of those environments, preparation and planning is going to prevent poor performance. So this is not something you should be thinking of as an afterthought. It's actually something that you should have already planned for. We've got our evacuation criteria. And at the end of the day, if anyone is suffering from any of these issues, the cure is going to be coming down, is going to be descent. In terms of the AMS, it's possible that we can progress and we can continue with what our mission or our goal might be, i.e. ascending whatever mountain that it is that you're visiting. But you're going to need to do that in conjunction with your body acclimatizing. And again, it says here, ascending slowly, 300 meters a day, but that might be too much for you, in which case you would have to go, at a slower rate. So first on my list, as I mentioned, is acute mountain sickness, or better known as AMS. So apologies for the really busy slide, but I felt that it was kind of important here that we understand or try and understand what these different illnesses or issues are. So the primary mechanism of acute mountain sickness is the body's response to hypoxia, which I've already mentioned. We've got an oxygen depleted atmosphere, and our body is trying to get used to working with less oxygen. So the low oxygen levels at those high altitudes are going to trigger a cascade of physiological responses. The most obvious are going to be breathing faster, so hyperventilation, because your body is trying to take on board more oxygen. That in turn is going to increase heart rate, and in an attempt to compensate for the decrease. Now, exact mechanisms to the symptoms of AMS are not entirely clear, but we do know that there are several factors that are thought to contribute, the first one being hypoxia. So that's leading to symptoms such as headache, dizziness, and fatigue. Second, we have vasodilation. So blood vessels in the body, including those in the brain, may dilate, and that vasodilation can cause an increased blood flow and contribute to the symptoms of AMS. And then we've got fluid shift. And high altitude can cause fluid shift within the body, and that's going to lead to an increase in fluid accumulation in certain tissues. So in terms of mild acute mountain sickness, you're looking at the patient having a mild headache, difficulty sleeping, anorexia, and shortness of breath whilst exercising. Now, they can continue climbing, but they're going to need much more time for acclimatization and most certainly rest. Moderate mountain sickness, the headache may actually be quite severe. It is possible to note that some lassitude and weakness, most certainly a loss of appetite. I've certainly suffered these symptoms myself, and nausea, and perhaps a difficulty to coordinate. I don't think I ever got that bad, but most certainly difficult sleeping, the headache, and the weakness were the symptoms. At the end of the day, you should climb down. Descent is a cure, and that's exactly what I had to do, and I quickly recovered. Severe AMS, well, that's characterized by the presence of pulmonary edema. So remember I said about leaky vessels and fluid being shifted and moving elsewhere into the tissues. If we've got pulmonary edema, we've got issues on the lungs, and if we have cerebral edema, then obviously we're going to have issues with the brain. So altitude cerebral edema, you're going to get your headache, you're going to get the vomiting, ataxia, lassitude, and a low volume of urine. Shortness of breath, and characterized by this cough as well. And that's kind of indicative of both cerebral and pulmonary edema. Confusion. At the end of the day, if you have hypoxia, imagine if you've ever come across a hypoxic patient, one of the first things they tend to present with is confusion. And they may have, some memory loss or even hallucinations. One of the issues with cerebral edema in severe mountain sickness is weakness or paralysis. And I've actually got a little slide that you'll see a little bit later on that kind of demonstrates it. And with pulmonary edema, remember I said about this fluid going somewhere, and we're looking at flooding of the pulmonary alveoli and a marked shortness of breath, even when the patient's at rest. As I've already mentioned, descent is the only therapy. Oxygen is what the patient needs, and it's arguably a lack of oxygen that's caused the problem in the first place. So if we break it down, acute mountain sickness, the lesser of the three, a lack of appetite, nausea or vomiting, fatigue or weakness, dizziness, issues in terms of our peripheral tissues. So you may get swelling of the fingers and the swelling of the toes. Insomnia, difficulty sleeping. I think for me, when I was working at altitude, it was the insomnia that I got first. And I noticed as I was kind of going to altitude that I was sleeping a lot less because I just couldn't sleep. And otherwise, I kind of felt fine, no issues. But then as I got even higher, it got worse with the headache, etc. But insomnia was the first thing that kind of got me. Certainly for us as maybe mountain leaders, as medics, as team members or team leaders, you know, we should be keeping an eye on each other. It's not usual or not normal that we would go to these places on our own. We're usually part of a team. So these are things that we should be looking out for all of the time. It's not a reactive thing. It's arguably a prevention thing. And it might be you've got people that, you know, that have traveled to these altitudes, you know, quite regularly, but they can still suffer the same as everybody else. So in terms of the treatment, obviously descending, or if you are going to progress, you need to rest at that altitude for a certain period before you progress. There are drugs that we can use. I'm going to talk about them in a second. Acetazolamide is one of them, 125 milligrams twice a day. And we can use ibuprofen as well. Normal dose is around 400 milligrams, and we take that as we need to. So acetazolamide is kind of a favorite when it comes to treating mountain sickness or mountain illness, and it works by stimulating ventilation or increasing our breathing rate, because remember we said it's oxygen that we need. So if we breathe faster, arguably we're taking on board more oxygen, and increasing the excretion of bicarbonate in the urine. So these actions themselves help to correct a respiratory can't pronounce it, it's been a long day, alkalosis, a condition where there's too much bicarb in the blood. And again, we're getting that because of the reduced amount of oxygen at the high altitudes. And again, this is the body's physiological reaction. Ibuprofen, everybody knows ibuprofen, and most certainly for its anti-inflammatory properties, and it may help alleviate the symptoms by reducing inflammation in the blood vessels and tissues. So AMS involves inflammatory responses, and ibuprofen's anti-inflammatory properties can mitigate against that response. So it's most certainly something that you should be taking in your medical kits and in with your drugs, along with your acetazolamide. So second on our list then, high altitude pulmonary edema, but really this goes alongside cerebral edema as well, and they are both life-threatening. So high altitude pulmonary edema, again, apologies for the busy slide, but hopefully you guys will have this. You can screen print it or screenshot it so that it's something you can remember. But HAPE is a severe condition. So that's obviously going to occur at high altitude. Again, the exact mechanism is not fully understood, but we do know that a lack of oxygen or a significant lack of oxygen is an issue. So we get hypoxic vasoconstriction. So the blood vessels in the lungs are going to narrow. And in HAPE, that vasoconstriction, obviously it becomes excessive, and that can cause an increased pressure in the pulmonary blood vessels, and that increase in pressure leads to pulmonary hypertension. We then get the leakage of fluid into lung tissue, and that's where we then get our fluid shift and we end up with pulmonary edema. So inflammation and oxidative stress further contribute to the condition itself. Again, symptoms: shortness of breath, cough with a frothy or pink tinged sputum. So again, things that we need to be mindful of when we're looking at people, when we're checking people. These are the things that we're looking for. Fatigue, chest tightness. The cure, or should I say the treatment, is immediate descent and medical interventions as necessary. Of course, oxygen. So that means we should be carrying oxygen with us as well if we know that we're going to be working at those altitudes. Most recently, I was watching a program on Discovery Channel that was in Peru, and it was about gold mining in Peru. And one of the team members actually went down with what they believe was cerebral edema, but he was having horrible headache. He was actually vomiting. He was being really sick, and again, they had to get him down. They had to give him oxygen. They had to give him medications, etc. So it does happen. The rest of the crew were absolutely fine. So as I said, in pulmonary edema, as you can see, we've got our alveolar sacs here, and we've got blood, but we get this vasoconstriction, so that brings up the blood pressure in the lungs, and we end up getting the leakage. And of course, the only place for that fluid to go is into the alveolar sacs. Symptoms are similar to bronchitis. So we get this persistent dry cough. And if you do get a cough and they do get any sputum, again, we need to be looking for the blood-stained frothy sputum. They may have a fever and shortness of breath even when they are at rest. Again, treatment, descend, but we need to get them on oxygen. Now, again, being in a remote, austere, wilderness type environment, we have what we carry, and what we carry is going to limit us because we're going to need our own personal equipment. We're going to need, everything else we need: food, water, personal equipment, climbing equipment, or whatever, to be able to actually work and do what we want to do at those environments. And then we've got to add to it medical equipment. So it's all about what you can carry, and it's going to be limited. So you may only have, one oxygen cylinder that potentially at 10, 15 liters a minute is only going to last you 20, 25 minutes. So we have to be very mindful of how we give our oxygen and how much we give. Again, the emphasis being here is on descent, because we know that the lower we get, the higher the concentration of oxygen in the atmospheric air. Nifedipine, 20 milligrams, is another drug that we can use. That's a calcium channel blocker, and that actually helps to dilate the blood vessels. So that helps to reduce this pulmonary artery pressure. So actually it's a very useful drug, and most certainly one that you want to have in your inventory. So next here we've got high altitude cerebral edema, and I don't know if any of you out there recognize this picture, but this was actually taken on Everest, and it was only a few days ago, where one of the Sherpas has rescued a climber who is suffering for a high altitude cerebral edema, and I understand that the climber was actually paralyzed. Now, again, what you have to understand is the physiological changes and issues to the rescuers here, not just the climber that's being rescued. Sherpas, they are amazing people. I've worked with many Nepalese guys. When I was in the military, I served with the Gurkhas as well. These guys are supermen, and if you are thinking of going to any of these areas, these are the guys that you want to have with you, because they live at these altitudes and their bodies have actually changed and adapted to be able to work at these depleted oxygen atmospheres. So those of us, or most of us, that usually live at sea level, we're the ones that are going to have the issues in terms of acclimatization, whereas these guys, they're literally able to function normally because they're used to living, born and bred at these altitudes. A superhuman feat here, whereas between back down the mountain. Not forgetting, as you can see, it's not only about moving the person, they've got oxygen there that they were also having to carry, as well as other equipment. Logistically, it takes an awful lot to be able to get people off the mountain, and unfortunately, as most of us know, Everest, Annapurna, there are other mountains similar to Everest that are very unforgiving, and unfortunately the bodies of those have succumbed to HAPE and HACE, litter unfortunately the mountainside. So HACE, high altitude cerebral edema, severe, life-threatening. It can occur at high altitudes, as we know, so usually above 2,500 meters, and it's going to affect the brain. So again, exact mechanism is not wholly understood, but believed to be primarily caused by a combination of hypoxia and an increase in cerebral blood flow. So there are compensatory mechanisms that the body will start to do as well. So when a person ascends, the air pressure obviously decreases, we get our lower oxygen availability, and we get hypoxia, and especially in the brain. So the body is going to attempt to compensate by increasing blood flow, and that creates cerebral vasodilation. But that increased blood flow, whilst it helps to deliver more oxygen to the brain, in HACE, the process becomes what we describe as dysregulated or excessive. In other words, it's too much. The body overreacts, and that can lead to an increase in the permeability of the blood-brain barrier. We get leakage, and we actually get edema and swelling in the brain itself and outside of the brain. So blood-brain barrier, protective layer of cells, prevents many substances from getting into the brain tissue. But with increased permeability of that barrier, that's going to allow fluid and other substances leak into the brain, and that's where we get our cerebral edema. So the swelling can lead to increased intracranial pressure, so we get a rise in ICP, and that results in symptoms, and this is where we get our severe headache. Anyone who gets a severe headache, they go back down the mountain. It's the best cure. If they're getting confusion, loss of coordination, seizures, as I said, in the instance of the rescue that happened most recently, the climber was paralyzed and he could not move. So here we go, our high altitude cerebral edema, and we can see, where we get our fluid accumulation. So we got our leaky blood vessel, and we get fluid that's leaking, and of course that causes the raise in ICP. So symptoms, like I mentioned, headache that does not respond to analgesics. The person is unsteady, they walk in an unsteady fashion, and you're going to get a gradual loss of consciousness. Increase in nausea and vomiting, and it's like anything, if anybody is vomiting, you've got to be pretty sick to start vomiting. So again, this person is sick and you need to take them down the mountain. In worst case scenario, we're looking at also retinal hemorrhage. So we're actually going to get bleeding into the eyes, and you'll see rupture of the small blood vessels in the eyes. So we have to be very mindful when it comes to doing our clinical and our physical assessments. Don't forget your C, A, B, C, D, E primary examination, and then look at more of a concentrated examination when it comes to the lungs for pulmonary edema, and being able to do a neurological exam if we have concerns over cerebral edema. Again, treatment, descend, oxygen, and a gamma bag. A gamma bag, I'm going to explain what that is in a second. And we also have another drug that we can add to our list, which is dexamethasone. Dose here is 4 milligrams twice daily. So prophylaxis and treatment, and I'm going to look at this kind of holistically in terms of all of the conditions. Again, here is another sign from Annapurna that again is warning people of any symptoms and what you should do. And to be honest, you'd be surprised. I guess it's not quite like the Lake District, but you do get people that are arguably amateurs, and they think that because they see everybody else climbing a mountain that they are able to do the same, and maybe they're not as prepared physically, mentally, or even with equipment, as other people are, and they may suffer from these issues. So it's necessary to warn people what to do. I think it says it there. It's all on the tin. Descend, descend, descend. Don't let anyone with acute mountain sickness descend alone. So nobody comes down the mountain on their own. If they do go down on their own, they may end up, you may end up finding them when you make your way down. So we can treat, we can prevent. And I've mentioned about acetazolamide, so Diamox, you may have heard it, 125 milligrams PO. We usually start 24 hours prior to our ascent. And as I said, that's going to increase our breathing and respiration rate and hopefully increase the amount of oxygen that we are able to use. And acetazolamide is something that can be used as a prophylactic treatment. If we do have somebody that suffers symptoms, we can actually increase the dose of Diamox to 250 PO. And obviously alongside your supplemental oxygen. We've got nifedipine, so 30 milligrams, again, per oral, 12 hourly, and that would be used for HAPE, and then dexamethasone. Now, dexamethasone can actually be used intravenously as well. So again, this is important that you do a thorough examination and come up with your diagnosis. But if we've got acute mountain sickness, then 4 milligrams, 8 milligrams for HACE. So dexamethasone, which I've mentioned, it works by several mechanisms. So dexamethasone is extremely important drug to have in our armory when it comes to treating mountain sickness. So it has several properties that includes, but not limited to, anti-inflammatory effects. So it's a potent anti-inflammatory, reduces inflammation in the brain tissue, and it does that by suppressing the immune response. And that's going to decrease the release of these inflammatory mediators that we get with this physiological response. Of course, that helps to prevent or reduce swelling and damage that we get with cerebral edema. The anti-edema effects mean that that the dexamethasone has the ability to decrease the accumulation of fluid in the brain tissue by reducing the capillaries' need or ability to leak. So reduces capillary permeability. It can stabilize the blood-brain barrier, and like I said, it prevents further leakage of fluid and substances into the brain. And then we've got our antioxidant effects. So dexamethasone also exhibits antioxidant properties, and that's going to help protect the brain tissue from oxidative stress. So high altitude conditions obviously lead to an increased production of reactive oxygen species, so that contributes to tissue damage. And the dexamethasone helps to mitigate that oxidative damage. So the Gamo bag. So this is our portable compression chamber or recompression chamber. It literally folds up. You do have to blow it up, and you are going to need a pump to be able to facilitate that. But it can literally be rolled up. It can be carried in a bag. It can be transported, so it can be used with a helicopter, or it can be carried or kept at a base camp or something similar. Most certainly used for patients where we're unable to descend because of the environment. So by using a foot pump, we inflate the bag, and we inflate it to what we would call a sub AMS altitude. So if we've got an altitude where we know that person was well and had no issues, then that's kind of the guideline that we would use. And if the Gamma bag does not have its own internal altimeter, then we would obviously need to add one inside with the patient and keep an eye on it. As you can see there, it's got windows, but what it does mean is you can't get to the patient. So the patient is in there, they're on their own, and the only way that you would be able to get to the patient to carry out any kind of intervention would be to unzip the bag, deflate it, to get access to them. So again, there's a downside to this, but once the patient's in there, they are arguably at a lower altitude, in which case they should start to recover. So in terms of the construction, it's very well made. If you can imagine how our vacuum mattresses are made, it's made of very similar material, kind of polybutyl type material. We've got a relief valve, we've got an intake valve. You need a valve there for your foot pump, and you're going to need a SVIG. You're going to need an altimeter there to be able to see what the pressure is inside the bag, and you've got your windows as well. It can be carried, so you've actually got carrying handles, and it can be used to move your patients down the mountain as well. So it's a great piece of kit. So I've got a couple of links here that I've put in terms of guidelines. So actually, if you go to the Wilderness Medical Society's webpage, you can actually copy that link. So if you've got the opportunity now, just do a screenshot of that. You can follow that link, and it will take you to a full set of treatment guidelines for AMS, HAPE and HACE, and it will also outline prophylaxis and treatment for the condition of mountain sickness. So what I'm going to do now is open it up to questions. Of course, at any time, if any of you have any afterthoughts, anything you want to ask us, there is my email address. And if you put altitude medicine question, I will do my very best to answer you. So what I'll do is I'll just stop that for now and come out.
Federico has a question.
Okay, just bear with me a second.
Hi, can you hear me? Hi, Tim.
I can, Federico. How are you? Yes.
Thank you very much for your presentation. I just was wondering if you normally see a progressive picture